Despite concerns over using either dopamine or diltiazem alone to provide renal protection, an infusion of dopamine plus diltiazem has been shown to increase creatinine clearance, osmotic clearance, and free water clearance with no increase in markers of tubular damage. Despite evidence of benefit in some trials, N-acetylcysteine given intraoperatively has generally not been shown to be effective in preventing renal dysfunction in patients at high risk. Postoperative oliguria and acute kidney injury. A. The use of hemodilation during cardiopulmonary bypass expands the extracellular volume and usually produces an excellent urine output in the immediate postoperative period. Oliguria is considered to be present in the postoperative cardiac surgical patient when the urine output is less than 0.5 milliliter kilogram hour. Transient oliguria is commonly noted in the first 12 hours after surgery and usually responds to a volume infusion or low-dose inotropic support. However, the presence of oliguria is usually a manifestation of an acute renal insult caused by prolonged hypotension or a low cardiac output state. The serum creatinine will frequently be lower immediately after bypass due to hemodilation and may have a delayed rise despite a marked reduction in glomerular filtration rate, as it takes time for creatinine to accumulate in the bloodstream. Thus, it is important to recognize that acute kidney injury may be associated with an abrupt and sustained decrease in urine output and or a sustained decline in glomerular filtration rate, eventually evident by an increase in serum creatinine. Measurement of biomarkers, as noted below, may be the most sensitive means of early detection of acute kidney injury. B. Definition of acute kidney injury. The instance of postoperative renal dysfunction depends on its definition. A classification system, RIFLE, has been devised to identify progressively worsening degrees of renal function. Since the function of the kidneys is both elimination of nitrogenous waste products and production of urine, either the creatinine level, glomerular filtration rate criteria, or the urine output criteria can be used for classification in this model. It should be noted that urine output is determined by the difference between the glomerular filtration rate and the rate of tubular reabsorption. Therefore, if the glomerular filtration rate is low from chronic kidney disease in association with poor tubular absorption, the patient can have good urine output initially. With acute kidney injury, tubular absorption is initially normal with a low glomerular filtration rate and then falls. In the RIFLE system, Table 12.4, the RIFLE criteria for classification of renal failure. Risk: serum creatinine, glomerular filtration rate criteria, urine output, overall instance. Increase in serum creatinine 1.5, decrease in GFR more than 25%, urine output below 0.5 milliliter kilogram hour 6 hours 20-25%. Injury: increase in serum creatinine twofold or decreasing glomerular filtration rate more than 50%. Urine output decrease 0.5 milliliter kilogram hour for 12 hours. Overall instance 5-7%. Failure: increase in serum creatinine threefold, decrease in glomerular filtration rate more than 75%, or serum creatinine more than 350 nanogram mole liter, or acute serum creatinine rise more than 44 nanogram mole liter. Urine output 0.3 milliliter kilogram hour for 24 hours, 1-3% overall incidence. Loss, persistent acute renal failure with complete loss of kidney function more than 4 weeks. End-stage kidney disease more than 3 months. In the refill system, the first category of acute kidney injury is defined by an increase in serum creatinine 1.5-fold or a decrease in glomerular filtration rate more than 25%. Approximately 20% of patients will develop this degree of ACI with a 1% requirement for renal replacement therapy and a 90-day mortality rate of 8%. The second level injury is defined by a doubling of the serum creatinine or a decrease in GFR more than 50%. This corresponds fairly well to the 2011 CTC database specifications definition of acute kidney injury, which is an increase in serum creatinine to more 2.0 milligram deciliter and twice the preoperative level. This occurs in about 5 to 7% of patients and is associated with a 7% need for renal replacement therapy and 21% 90-day mortality. Patients in the third category failure require dialysis 55% of the time and they have a 90-day mortality rate of 33%. However, once renal replacement therapy is necessary, the mortality rate is usually about 50%. An elevation in many kidney-specific markers is common after open heart surgery. A significant elevation in plasma and urinary levels of biomarkers such as NGAL, cystatin C, kidney injury molecular 1, KIM2, and interleukin 11, 18 may be noted within 2 to 6 hours of surgery and has been found to correlate with the extent and duration of acute kidney injury. These are valuable early indicators of acute kidney injury that precedes elevation in serum creatinine levels. Also, cystatin concentration reflects baseline glomerular filtration rate more accurately than serum creatinine. NGAL is rapidly induced in renal tubular cells in response to ischemic injury, and also its early appearance is independent of GFR. It is generally predictive of a subsequent decline in glomerular filtration rate. In patients developing early acute kidney injury, plasma NGAL levels more than 150 nanogram milliliter and a 15-20 increase in urinary levels have been reported. Because elevated NGAL levels may provide for early diagnosis and intervention of incipient ACI than elevation in serum creatinine, some authors have recommended that all patients have baseline NGAL levels obtained for comparison with serial postoperative values.